The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, and good evening, depending wherever you are. Welcome to today's ISQua webinar on Patient Experience is Not Patient Satisfaction, Understanding the Fundamental Differences. Our presenter today is Dr. Subhashini Devkaran, who is a regional leader in quality, patient safety, and patient experience. She has held several leadership positions in quality and patient safety in the Middle East and South Africa. Subhashini led various hospitals through quality certification, hospital accreditation, and regulatory audit programs. She continues to serve on various regulatory committees and leadership societies in the Middle East. Currently, Dr. Devkaran is an accreditation manager in Quality and Patient Safety Institute, Cleveland Clinic in Abu Dhabi. She is also a vice president of American College of Healthcare Executives in MENA region. Just to remind you that Dr. Devkaran's presentation will take approximately 45 minutes, and we will leave 10-15 minutes for any questions that you may have at the end. Please type your questions in the question box provided, and we will do our best to answer them all at the end of the presentation. I hope you will enjoy this presentation, and over to you, Dr. Devkaran.
Thank you, Juliana. It's a pleasure to speak to you today about something that's really, really important and very much on top of the agenda of most healthcare leaders in the region and internationally. So today, just this a recent survey has shown that patient experience and patient satisfaction is the #1 priority for healthcare leaders. And that really trumps clinical quality, even cost reduction, and other burning issues. So today, I'd like to talk to you about 3 objectives. I want to talk to you about the conceptual flaws of patient satisfaction and how we can understand the differences between patient satisfaction and patient experience, and then taking patient experience and its relationship to patient safety and its link with patient-centered care. So it's hard to believe that a little bit more than a century ago, we were told that if we were meant to fly, we would have wings, and then the Wright brothers actually created the first flying aircraft. It's strange to believe that right now, aircrafts contain hundreds of people, as well as wonderful amenities from showers, beds, and services on an airline. Healthcare, too, in the past, was very low tech, but as you can see from this picture, very high touch, whereas in recent times, you can see healthcare has evolved to being technology driven, but actually people light. So what's next in healthcare? Well, we know where we have been and we know where we are going. We're moving from a fragmented care system to more coordinated care, from provider-centered care to patient-centered, from paper to electronic, and we want patients to move away from being passive participants to being fully engaged. And really the question will be, from our experience and satisfaction perspective, from what's the matter with you and how can we help, to what matters to you as a patient and how can we meet your needs. So does anybody have any idea as to how many people interact with a patient on a daily basis? Is it 1, 2? Well, studies have shown that it's 17 to 25 people that interact with a patient in just 1 episode of care. And as you can imagine, it's very, very complex to collect patient satisfaction or patient survey data. So let me make it very simple to you in terms of understanding the difference between satisfaction and experience as a concept. So in recent times, during the recent economic downturn, the sale of luxury cars was at an all-time low, except for one brand, which was the Lexus brand, because they had a different marketing strategy. You see, Lexus never waited for buyers to enter their showrooms. Rather, they would go to parties, and during just casual conversation, they would say, well, what car do you drive? And usually they would answer the question with something or the other that was not a Lexus. And then they would say, well, I have this brand new RC 350. Would you like to take a drive? And I'm sure of you, many can relate that you were satisfied with your old automobile prior to have driven a brand new luxury car. The experience of driving that luxury car, of course, increased your expectations and lowered your satisfaction with your present vehicle. And that's why in healthcare, high levels of patient satisfaction do not actually talk about a high level of quality care. See, satisfaction is a judgment of whether expectations are met. And that varies from person to person, and that makes it a very subjective measurement. In fact, positive satisfaction ratings may even be present in the face of negative patient experience, unless they believe that that care is under the control of the person that they are evaluating. For example, a physician who appears to be very hurried would be forgiven if they thought that this was due to his time constraints, but not to his personality or his behavior. You see, high satisfaction ratings, I say, is fool's gold because it may not indicate care of a superior quality. In fact, low ratings may actually talk about problems, but could be masked by reporting adverse events. In fact, pitfalls of patient satisfaction is that improvements in patient satisfaction have not been linked to quality improvement. Studies have shown that there is no evidence about how patient satisfaction data is used for quality improvement because it's just not actionable. And in fact, there's a lack of a universal acceptable definition to make patient satisfaction comparable. And the reason is that it's hard to compare patient satisfaction that is sometimes treated as an outcome measure and sometimes as a process measure. An outcome measure in a way that it's reflected as health status by a treatment, and then as a process measure, in fact, in the way that care is delivered. So patient satisfaction as a concept came from quality management and marking in the industrial sector. So the focus was really on productivity and efficiency and driven by the agendas of managers and in healthcare clinicians. Patient satisfaction as a survey tool was not based on what was more meaningful to patients. Patient experience as a concept is much more reliable. Studies have compared the two and showed that only 4.6% of variance in patient satisfaction scores were actually differences between practices. The rest were because they were differences between patients. Whereas patient experience, more than 20% of the variance was actually due to the responses. So what is the difference between the survey tool of a patient satisfaction survey and one of patient experience? Well, patient satisfaction surveys actually ask subjective questions about the care. So some of the questions could be, how would you rate your doctor's caring and concern for you? How satisfied are you with the appointment system in your healthcare? Or is it easy for you to get medical care when you need it? So the questions are usually multiple choice and very subjective. The rating scale is usually strongly agree to strongly disagree, very good, good, fair, poor. Those are the types of numerical scales that are used. Whereas experience questions actually want you to measure the patient's actual objective experience and aim to measure just one episode of care or one clinician, one provider. So here are some examples. In the last 12 months, how many days did you actually have to wait for an appointment when you needed care right away? So that could be the same day, 1 day, 2 to 3 days, 4 to 7 days. It's really very quantifiable. Another question would be, in your last 6 months, how often did you see your provider within 15 minutes of your appointment time? So you could say never, sometimes, usually, or always. Another very quantifiable measurement scale. So prior to talking about empathy, I just want to tell you that there is a very clear difference when it comes to patient experience around a nurse acting towards best quality standards and a nurse who's actually working with empathy. So what is the difference? It can be quite confusing conceptually, so let me explain further. In the first case, the work is performed in a very excellent manner. She asks the right questions, she's polite, she smiles routinely, and at the end, we're not sure if her friendliness is automated or if it's actually genuine. Whereas, let's think about a nurse who is able to empathize with the patient, get into those storm of emotions that a patient comes in with into a healthcare organization. Not just look at the clinical perspective, right? Really look at the patient holistically, look for solutions in patient problems, speak the patient's language, advocate for the patient, challenge doctors if needed, and really, patients value this. They like to think that we were comforted and acknowledged. And to demonstrate that, I'd like to share with you a video on empathy. Now this video will not have sound, but I'd like you to look at the text. It's very meaningful. So that video really put into your understanding the word of empathy. And that very much links into the difference between patient experience and patient satisfaction, because patient experience as a concept strives to go way beyond making patients happy by just answering politely and doing the right things at the right time. In fact, patients that we have interviewed have told us that even though the experience was positive, their negative outcome was there, but the experience was still positive. And some patients that have had a positive outcome may have had a negative patient experience. And patient experience as well is very crucially linked to employee engagement. Patients judge healthcare providers now not only on patient outcomes or clinical outcomes, but on compassionate and excellent patient-centered care. So patient experience as a concept goes beyond us knowing, well, 10% of patients value their care as poor or waiting times are fair, really does not help us as healthcare leaders make the changes that are necessary to improve on those areas. Instead, patient experience provides us with really precise details about what went wrong during the care. Was it around communication? Was it around patient understanding of medication? And that's what makes the difference, where we can make it an actionable process. And therefore, the main difference between patient satisfaction and patient experience is what values are prioritized. Is it the organization, or is it what patients need? And that is why it's integral to patient-centered care. Applying patient experience means that we put patients first instead of our own needs. So here is a quick example about a patient experience survey, and it looks very standard to the usual survey instruments we use. So we cannot tell from this picture or this graph what did we do when patients were dissatisfied. I mean, what do we do to improve on this graph? It's not specific, it's not actionable, it's just data. Whereas this is one about the care of nurses, and this is a patient experience survey, and you can see the scale that was used: always, most of the time, half of the time, seldom or never, and we can identify the specific service behaviors that we want to improve upon. So we can see, did nurses talk in front of you as if you weren't there, and that was 16% said always. We can drill down that data to the unit where this actually was surveyed and modify those service behaviors immediately from looking at the results. So patient experience is also very important because it has been linked to patient safety. When nurses communicate well at the bedside, really effectively, research has shown that medication errors go down, pressure ulcers go down, and falls as well. And that's patient safety. When physicians coordinate care better, they communicate better, the compliance with treatment options improve, and that improves clinical quality. And there is also some evidence that has been published that suggests that patients can be used as partners in identifying poor and unsafe practice and help the effectiveness and patient safety. So there is a small but growing body of evidence that shows that integral relationship between patient experience and clinical quality. In fact, this is the triad of patient experience, patient safety, and clinical effectiveness. This is the patient quality triad. Many organizations abroad as well are starting to use patient experience scores as a financial imperative. Reimbursement in the United States, 30% of which is based on patient experience scores. As I said, a 2013 survey showed that patient experience really trumps patient safety. But it's really complex. As you can see, there are different service points, and a patient's emotional state varies between the different service points. You can see that during a clinician intervention, this state peaks. It's a very stressful, emotional journey for patients. So I conducted a study to understand that as patient experience is a very emotional journey, and if we could actually modify service behaviors, which particular service behaviors would be of value to patients? So what are the most influential factors in a patient experience journey? And are these modifiable? Can we improve upon them? And if we do modify these, what is their influence on the actual patient experience? Would it be positive or negative? So based on these three hypotheses, I conducted a study in the UAE. There was a research gap because patient experience as a concept is unexplored. There were only 2 research papers in the UAE. Most of the research on patient experience could not be generalized because they were really specific to a specialty. As I said, no experience on patient experience in the region and no assessment tools. So I had to create and validate a patient experience survey tool. I designed a method of survey design, which I call the COMPASS method for survey design, and then took some learnings, really important learnings from the Picker Institute, the published literature, and then of course the HCAP survey tool, which is used in the US. What's very important is that the methodology for survey administration was face-to-face. Face-to-face interviews have been shown to be much more better or superior in terms of getting completeness of data, but also in making sure that the response rate is higher. We used a 5-point Likert scale and of course had to be very rigorous in the translation of the survey. We wanted to cover the entire patient care journey. As you've seen earlier, there are many service points and those vary according to the emotional state of a patient. So we covered all areas from the area where patients were admitted, waiting for admission, right across until discharge. We designed the survey using pictograms, English and Arabic, but also making sure that they were very, very clearly defined. We used care from nurses, pain management, medication management, covering the whole area. Also, we wanted to do demographic analysis. We wanted to drill down to the predictors of patient experience. We validated the tool. We then wanted to identify the variables that contribute the most to patient experience and to identify what predicts positive patient experience, and then look at the socio-demographic characteristics. As we know, patient experience as well as patient evaluations of care is very specific to a patient's characteristics. We interviewed 500 patients. Our survey tool was 60 questions long, with covering 13 survey domains. We conducted face-to-face interviews with these 500 patients, and we wanted our patients to stay at least 24 hours in the hospital, and we interviewed them on the day of discharge. From the demographic, 35% of our patients were local, were Emirati-based. We conducted various stages of analysis, from descriptive statistics to logistic regression analysis. We also wanted to measure what patients value. We asked them to rank what was important to them in the survey tool. They ranked the care from doctors and the care from nurses as their top priorities. We also looked at the literature and we found that gender, age, educational level, physical health, length of stay, and nationality were some of the predictors. We found that physical health status in our study a positive physical health status resulted in a positive patient experience score. In fact, patients with a positive health status were 4 times more likely to recommend the hospital than those who were not. Education had no effect. and gender had no effect. Whereas previously it was thought that the female population would be more discriminating, our study did not reflect those findings. Length of stay was another predictor. Patients who stayed longer in the hospital had lower experience scores. And this could be because they had more opportunity to experience flaws in the healthcare system. Patients that had a positive treatment outcome also had a positive patient experience. But there was no literature to support that finding. As we thought from what the patients had ranked, care from doctors and care from nurses were very important predictors in the patient experience scores. Cleanliness, pain management, and hospital food were also very important predictors of a positive patient experience. And this was surprising to us because both cleanliness and quality of hospital food are service-related aspects, whereas pain management is a clinical aspect, and it shows that patients are very much concerned about their clinical care. So what are organizations doing internationally to improve on patient experience? So unlike patient satisfaction, where a lot of the initiatives are based on service aspects, patient experience tries to drill down to the clinical aspects or things that are of concern to patients. So some best practices are hourly rounding programs where nurses would round on the unit on an hourly basis, ensuring that patients are safe, ensuring that they've been assessed, ensuring their pain is in control, and creating that expectation that they are available for the patient's needs. Sharing patient experience stories have been a very powerful tool in organizations to engage staff and healthcare providers. Leadership rounding as well has also proved to be effective. Leaders round not only engaging the staff in the program, but also asking patients how their care was provided and whether or not they had a positive experience. There are various staff training programs working on empathy, working on positive communication skills as well. So Juliana, we have a poll, and I'd like you to launch the poll. The first question is, which of the below is not a patient experience question?
The poll is now displayed, and we have a couple of options there. If you can pick one of them. The first one is how often were educated about medication by the nursing staff. The second, how would you rate the food quality? The third, how often were you assessed for pay? The fourth, how long did it take the nurse to answer the call bell? And the last one, how long did you wait to see the doctor? We can see that the poll is now in progress, and only 17% of the audience has voted so far. So we will give a couple of more seconds to see the final results, and I will display the results on the screen for everybody to see. 52% voted, so we can see the votes are still coming in. Okay, so we give it another couple of seconds. We can definitely see the two questions that are taking the lead in this poll. As I understand, only one of them can be correct, but okay, so it seems that the audience has voted, and I will display the votes now.
Yeah.
Just
so Juliana, Would you be able to share the poll results with us?
Sure. We can see that there are two answers that basically got the most percentage, and the first one, 33% of the audience have voted for the first one. How often were educated about medication by nursing staff? And 52% voted for how would you rate the food quality. So I will just hide the poll results now, so we can give the audience view back to yourself, Dr. Devkaran. Okay.
Thank you, Juliana. So the correct answer is actually number 2. How would you rate the quality of food or the food quality? So question 1 is incorrect because it's a quantifiable question. How often were you educated about medication by the nursing staff? So it's quantifiable, and that would be whether it was on a daily basis or every time, frequently, mostly, sometimes, never. Whereas how would you rate food quality is correct because you could say that you were satisfied, not satisfied, or it was good, fair, or poor, which is a very subjective measure and not quantifiable. I would like to move to the next question, Juliana, and if you don't mind displaying the poll. Question number 2 reads, what do patient experience ratings not intend to measure? And the first one is access to care, treatment with respect and dignity is number 2, involvement in treatment decisions is number 3, 4, the perception of quality care received, or 5, the patient's evaluation of what actually occurred. So which of the following is not a patient experience measure?
We will take a couple of seconds for the votes to come in. We can see that the audience is actively voting, and there is no single view on what of the following experience not intend to measure, like the ratings not intend to measure. So we can see that the views are actually spread across the couple of options. As the audience is voting, and we can see that 50% of audience has voted so far, we're just waiting for the rest of the results to come in. %64% of the audience has voted, and we'll get as many votes as possible. Okay, so 75% of the audience has voted, and there are no more votes coming in. So I'll close the poll, and we will display the results that are available to us at the moment.
Okay.
And we can see that 14% has voted for access to care, 14% has voted for involvement in treatment decisions, 29% voted for perception of quality care received, and 38% voted for patient evaluation of what actually occurred, and only 5% voted for treatment with respect and dignity. So I'll just hide the result.
Correct answer, yes. So the correct answer is actually 4, because patient experience ratings do measure access to care. So you could ask, how long did you wait to receive an appointment? Treatment with respect to dignity, you could ask in a patient experience survey, is how often were you treated with respect and dignity? Involvement in treatment decisions, very similar to the above. But 4, the perception of quality care received. Remember, that would be a patient satisfaction survey, which would mean that it would be very subjective to ask a patient about how they perceived the care that was provided, whether they were satisfied or not with the care that was provided. Whereas 5 is a patient experience survey, which asks about what was actually occurring during their experience or during their episode of care. So perhaps I'll clarify it in this slide, and you can see that satisfaction ratings actually reflect personal preferences, the perception of quality care that was received. Whereas patient experience really asks a patient to report in detail about their experience about an episode of care, either a particular service, a particular hospital episode, or a specific clinician. So they don't ask about the care in general, but about these specific particular services or episodes. The types of experience ratings could range anything from how would you rate your experience with confidence and trust in healthcare professionals, how often were you involved in treatment decisions, how often were you being treated with respect and dignity. Whereas patient satisfaction ratings actually speak about the perception of quality care received, as we said earlier, and their response tendencies. These are largely due to personal characteristics. And these are global satisfaction ratings, so they can be very misleading. And the general evaluation categories that are used in patient satisfaction, as I said earlier, is excellent, very good, good, fair, and poor. These are the common evaluation categories, whereas patient experience is quantifiable and actionable. And the question could be, how often did you have to wait for more than 15 minutes for the call button to be answered by the nursing staff? So that's very quantifiable. The problem with patient satisfaction is that fair or poor actually doesn't give managers or clinicians a view of what to improve, whereas patient experience does. So a patient's evaluation of what occurred is different than asking questions about what actually occurred. So we ask a patient about what occurred in general, whereas patient experience says what actually happened during your care. In general, patient satisfaction says, how would you as a personal, and these are all your personal preferences and all your personal characteristics, evaluate that particular experience, whereas patient experience says, what exactly was your experience? How often were you educated about medication? How frequently were you assessed for pain by your physician? So patient satisfaction, it really gives very general ratings of care, and that is why when you've worked in an organization, you'll find that it's most likely that your patient satisfaction scores will be relatively high, ranging from 80 to 90%. And this is really because of the false positives, whereas patient experience just asks very factual questions about events and occurrences. So to conclude, I'd like to say, from the video that you've seen, as well from our discussion here today, patient experience is a very complex subject. So I'd like to conclude with a little story. You have received a lot of information here during our webinar, and you have been equipped with a great understanding about patient experience as well as patient-centered care. So let me tell you a little anecdote. There was a gentleman who had reached ripe old age, and basically, during his last moments, met his two sons. He called upon his first son and he said, "Son, I have in my hand a bird, and I want you to tell me, is this bird alive or is it dead?" And the son looked and he pondered and he looked at his father and he said, "Father, I think this bird is dead. From the way you're holding and clenching your fist, I believe so." The The father opened up his fist and away the bird flew. The next son came in, and the father asked the son the very same question. Son, I have in my hand a bird. Do you believe this bird is alive or is it dead? The son pondered carefully and then looked deeply into his father's eyes and said, Father, I believe the life of that bird is in your hands. Because if I say that bird is alive, you will tighten your fist and that bird would be dead. If I say that the bird is dead, you will open up your hands and away it will fly. So essentially, Father, the bird's life is in your hands. The choice is yours. So, to conclude, the information that you've learned today is really yours to move along implementing your organizations. The choice is yours to move from a provider-centered care philosophy or to a patient-centered care philosophy. Thank you very much for your attention, and I'll be happy to answer any of your questions.
Thank you, Dr. Karen, for this very interesting and extremely informative presentation. We have a couple of questions, and the first one is coming from Derek, and he's asking, how do we verify or manage possible bias in the ratings of your survey?
Thank you, Tariq. That's a very good question. So when we designed the validated survey, we were very careful in our administration method. So to minimize bias, one of the biases that were minimized were actually recall bias. So the first thing we had to ensure was that using the survey method, that we had administered the survey on the day of discharge. Because once patients leave the organization, they're not able to recall the events that have occurred due to the huge number of people that they interact with. To minimize response bias, as I said, we did face-to-face interviews. And in this way, that the actual person that was conducting the interview was trained in the survey methodology and was able to carefully explain the question and the questionnaire to the actual survey participant. Another aspect of bias that was minimized was actually the surveyor bias, where the individuals that were conducting the survey came from an objective department. They were not involved in the care of the patient. The patient was actually enlightened about this fact and was told that all the information that would be provided is confidential and that the information that's provided to this individual is not going to go into or be viewable to the clinicians. It's not identifiable. So we've managed to minimize those types of biases.
Thank you, Dr. Karen. We have a couple of similar comments. They are both Upasana and Fatima thanking you for this brilliant presentation, and both of them are looking to get the copy of the study and the copy of the questionnaire. So if you're willing to share this information with them, I can put both Upasana and Fatima in contact with you, and you can take it from there.
Yes, I'd be delighted to assist them.
Perfect. Well, we have a couple of questions, and again, we have excellent feedback all the way around. Patricia McKernan in particular, thanking you for this excellent presentation, and she has a question for you as well. She is saying that many survey questions include comments, for example, NRC. Can you please comment on the utility of the qualitative analysis of the comments in relationship to the rating levels as a means of capturing actionable patient experience data?
That's a very good question, Patricia. Thank you. So in the survey that we used, and a number of surveys that I've used in the past, often have a free text component where patients are able to describe any additional comments that relate to their care. These are of great value. When we've done a qualitative analysis, they actually very much marry or mirror the constructs that we've used in the survey tool. So if you look at service-related aspects like cleanliness as well as food quality, a lot of the patients will describe their negative or positive comments about those service-related aspects. So I found that the survey tool itself, because it was so comprehensive, managed to capture those issues, and that the comments were just there to support their evaluation of that particular aspect of care. So I would strongly recommend or suggest that you do include a free text area to allow patients to comment.
Thank you, Dr. Devkaran. The next question is from Marianne Street, and she's asking you to describe the 13 domains you included in your survey. I think she might be relating to one particular slide.
Yes, there is a slide, so I'll go back to that slide just to show it to you. So the 13 domains that were covered is actually this slide. So here are the 13 domains. So we covered the aspects. You're waiting for admission, where we asked about how long did they wait for admission, etc. We talked about medication management, particularly about education around medication, potential side effects, quality of hospital food, care from doctors, care from nurses. Here, these two aspects, we talked largely about the conduct, the service-related behaviors, treatment with consistency in the decisions that were made between nursing, communication between nurses and doctors as well were included here. Management of operations and procedures. Here we looked at various aspects about the care, how often were they educated, about the risks and the benefits of the procedures, then around cleanliness, treatment with respect and dignity, consistency and coordination of care, patient rights and feedback. So here we talked around about how were patients informed about their patient rights. Pain management, how often were they assessed for pain management? How often did patients feel that they were involved in care decisions? And then discharge, and we asked many questions around the discharge process.
Thank you, Dr. Devkaran. We have a lot of questions coming in. So the next one is from Alam Archie, and he's particularly interested, how did you select your respondents for the survey?
Oh, that's a very good question, Alam. We had specific criteria, but at the same time, since we wanted to do a comprehensive study, we actually selected all patients during a specific time period. Now, I want you to understand the context in which the study was conducted. This was a multi-specialty hospital, and this hospital actually was tertiary level hospital. So it was not a specific obstetrics, gynecology, or pediatric hospital. It was multi-specialty, and what we wanted to do was cover the range of different services that were provided. So our criteria for selection was that we would survey all patients who had an inpatient stay of more than 24 hours, and we would survey them on the day of discharge. Apart from that, there were no other selection criteria because we wanted to have a very broad perspective.
Thank you, Dr. Devkaran. The next question is from Kalada Richard, and he is saying that you have mentioned you carried out 500 face-to-face interviews. He's particularly interested, were these interviews standardized or conventional, or a bit of both?
Sorry, I did not get the last part of your question, Ileana. Were they
standardized or conventional, or a mix of both? So he's interested in the...
They were standardized. Yes, the face-to-face interviews were standardized because they were built on a standardized questionnaire. The interviewers were actually trained to ensure that the questionnaire was standardized and that the interviews followed the same process.
Perfect. Thank you. The next question is coming from Atayo, and she's interested to find out how do you minimize for the bias of dealing with the patients who were ill and not unexpectedly impatient or cranky is the word is used here.
So how would we deal with patients? Well, basically, we would ask the patients if they would be open to conducting the survey with us. So would they partner with us? We'd explain very much the outcome of the survey and our intent of conducting the survey. And although I know if patients were in pain, we did not interview them while they were in pain. If patients declined, we would come back later when it was most suitable for them. So in that way, we managed to obviate or sort of mitigate those particular times where patients were cranky.
Thank you, Dr. Devkaran. The next question is coming in from Anne Stender. And her question stands as, should patient experience surveys always be accompanied by patient ranking of what areas that is important? Is satisfaction surveys in satisfaction surveys it is clear whether the patient is satisfied with the care or not, whereas as I can see it's not incorporated in patient experience survey.
Okay, so I'd like to just bring your attention to a few things that we did not include in the presentation. So apart from the 13 patient experience domains, and I'm just going to see if I can click through some of the slides. On the slide you will see that there are some overall questions. Let's see if I could find that for you. So when we both So yes, so here are some general areas where you can get the overall rating, so to speak. So even though we looked at the 13 survey constructs, you can have what we have implemented is the global rating sort of questions. One of them is, this is what we call patient experience outcome measures, is the overall rating of the hospital. So patients were able to rate the overall rating of the hospital. The overall patient experience score, which was an accumulation of the 13 patient experience constructs, their willingness to return to the hospital, and their willingness to recommend the hospital to family and friends. And this gives you a very nice overall picture of your organization. And it also gives you an outcome measure from the patient experience survey. To answer the first part of her question, should the patient's ranking of constructs accompany the survey? We did this for academic purposes, but in a usual survey, it's not necessary to ask patients to rank it, unless this is the first time that you're actually implementing a patient experience survey and that you're validating the tool to make sure that you are incorporating in the survey tool what patients actually value.
Thank you, Dr. Devkaran. Almost all of the participants are sending their comments how much they enjoyed this presentation. And we have comments from Aisha, who is saying, great presentation, very enlightening. We have also Patricia McKinnon and Dina Barodi that are also looking to get copies of the study or the questionnaire, the survey, and also the references. So as I said on a previous occasion that we will share that information. I will put all of the interested participants of this webinar with Dr. Devkaran, and she will take it from there. We do have a couple of more questions, and we still have a couple of minutes left, so we will continue with the questions. A question from Anne Stander again, and she's asking, in your study you investigated predictors of the overall patient experience. How was this measured, and how does it differ from an overall rating of care, satisfaction.
Okay, so let me just display that slide again that I had shown you earlier around the overall rating. So that's another good question. So when we looked at the overall rating, we actually developed multiple regression models to test the different hypotheses. So what we used was these outcome measures, the overall rating of the hospital, the overall patient experience score, willingness to return, etc., was where we used the patient demographics as well as the patient constructs. Now, don't get the terminology is the patient experience constructs are actually the different aspects of care that we measured. And what we did is when we looked at a regression analysis and then we looked at the coefficients and examined the predictors that came out of the regression analysis models. So that's the analysis that we actually did. Without making it overly complex, we just developed multiple regression models, actually building models, putting in the patient experience constructs. And when we came out of those, you saw that the results were around care from nurses, care from doctors primarily as being the most significant predictors, and then cleanliness, pain management, as well as the food quality were the main predictors from the patient experience constructs. And then when we looked at the patient demographics, you saw that there are various different constructs there around the health status, treatment outcome being one of the strongest predictors for the overall ratings.
Thank you, Dr. Devkaran. We have a very interesting question from Elam. He's agreeing with you how subjective satisfaction assessment is, but Parasuraman developed an assessment instrument to measure differences between perception and expectations. What do you say in respect to this in your statement of subjectivity?
Sorry, I just need you to, Yelena, just to repeat the last part of the question.
Yeah.
I didn't get that.
What do you say to that with respect to your statement of subjectivity? So the difference between perception and expectation.
Yes. So there are a lot of studies that have actually documented the difference between perceptions and expectations. It's, again, the whole terminology of patient satisfaction. There isn't a universal definition around patient satisfaction. So patient satisfaction goes into the whole discussion around how is it linked to the patient's perception of care. Patient's perception of care, how is that linked to the actual patient's expectations? So again, as I said, the whole idea of patient satisfaction as being subjective is that there isn't the universal definition about what patient satisfaction actually means. It's the tool itself is very weak. It doesn't give us any ability to make the actual results actionable. And as you can see from the final slide, actually the beginning slide. This slide actually details your question, Alam, is that the whole idea about patient satisfaction is that they are generally, the satisfaction ratings are high. What people tend to do is that they actually tend to have a 4-point scale, and when you use a 4-point scale, you actually force ratings to one direction because you don't have sort of a middle ground for patients to respond. So that's why most organizations get very high satisfaction scale ratings, because there are so many false positives in their rating.
Thank you, Dr. Devkaran. I think we'll finish the Q&A session as we are running out of time with this question. I think all of the participants asked for the copy of the survey at this stage, so I don't want to leave everything out and not to mention their names because I already lost count of all of them. So we will do the same. We will share the obviously provided that you agree, we will share the survey tool and the questionnaire with all of the participants of this webinar. So the last question of this Q&A session is coming from Aizhat Rahila, and he's asking, how effective was the survey finding and improving patient care? What improvement measures were adopted?
That's a very good question. So I'm very happy to report that the organization in which we actually implemented this particular survey has made great improvements in patient experience. They've started the hourly rounding program, which was wonderful in helping reduce fall rates, which is an excellent quality measure. And hourly rounding as a program itself, and I really recommend that most of you read or you can have a look at it online, some research around hourly rounding programs that has a direct correlation between patient safety. Some of the outcomes that were reduced, we know, was the number of call lights, that nursing efficiency was improved. As I said, patient falls was reduced. Some of the other improvements that were made was around communication. Some further improvement was around the continuing coordination of care, which was also very much an area of improvement because of communication programs that we established. And just the whole patient education, patient engagement process was something that the organization embraced and now continues to use the survey tool during their processes for improvement. So it was very easy to actually develop the action plans around the results of the survey. Whereas in the past, we were using satisfaction tools, and it was very difficult for us to understand, apart from improving the service-related aspects or the flows of the service, we were not able to judge what clinical aspects of care needed improvement. So that's a very nice way to end the session. Thank you for your questions. I'd like to thank the participants for their very informed questions, very well put together, and really enjoyed their participation in the session today. Thank you, Juliana, for helping coordinate the session as well. Appreciate your assistance.
Thank you, Dr. Devkaran. I would like to express huge thanks to you for delivering this webinar. So there is so much interest in the work that you are doing, and there are also a number of questions that haven't been answered. So with your permission, I will forward the questions on to you, and if you have an opportunity to answer them, we would really appreciate them, because there are still a good couple of questions left unanswered. I would also like to thank the audience for so many questions and for your positive feedback, and I would really appreciate also that you fill in the post-webinar survey to improve the quality of our service. Just to remind everybody that the recording of this webinar will be available on ISQua website within 24 hours of the live session, so please pass this information to anybody who might benefit from the information in this webinar. Please also note that the fellowship program participants who attended the live webinar would be able to automatically claim 2 credit points for taking part. We do have a number of new participants that have joined this webinar session today, so welcome to those. And also just to let you know that the participants who are going to view the recording of this webinar at the later stage will also be able to claim the credit points for attending this, for viewing this webinar, in fact, by answering the compulsory questions after the webinar. I would like to thank again Subhashini for this brilliant presentation. We really enjoyed it. You are doing tremendous work in your area, and we really appreciate you sharing your experience and your findings with us.
Thank you very much, Juliana. Really appreciate the participation of the audience, and I look forward to engaging with them on their comments and their questions at a later stage, and communicating with them around the survey tool and the publication on the study. Thank you very much.
Thank you so much. Have a good day, and goodbye.
Goodbye.